I'm Jane McDonald and very lucky to be the executive director of the Sept Hospital Foundation. Today's topic is early cancer detection, or what I always wanted to call screening palooza. There's so much information right now in the market about the different types of DIY, do-it-yourself screening, that we wanted to pull together today's topic so that everyone has a bit more information. May I ask for a show of hands, how many of you here today are without an assigned doctor or nurse practitioner? Okay. You are not alone, and thank you for sharing. There's up to 7,000 patients, we think, on the coast who are not attached patients, unattached patients, as they say. And while our emergency department and medical help will always be available to you here at the Sept Hospital, what can we be doing proactively to manage health? What about prevention? What about some of these new screening programs? And we hope today to provide you some answers and some hope and a couple of resources on how to navigate the system with or without a doctor. So as I often say to people, cancer loves a good running start. Unfortunately, it's thanks to our awesome medical imaging team, yay, and as well the BC Cancer Hereditary Cancer Program that I'm actually still standing here today. So it's living proof that between these two groups, they sincerely will not let you out of their sight, because once they find something, they will do everything in their power to vanquish the demons. So thank you again. Not going to cry. So I am absolutely... I looked at Nancy Seamus, she got me. Okay, so I'm absolutely thrilled to bring our experts to the stage today to talk about early cancer detection and screening programs available to all British Columbians, regardless of whether you have a doctor or not, so that we can help you, like they help me, and help you get ahead of cancer. So, as I get the opportunity to sort out the papers I've just lost here, I'd like to invite my speaker friends up to the stage, and while they're traversing said stage without tripping, allow me to give you a brief background. So we have quite a trio today. We have Dr. Ted Cricken, who is a family practice physician here on the coast, working at the Cowrie Clinic and as well Sept Hospital. And Dr. Ted trained as a family physician in Ireland, practiced in Saskatchewan, and now is settled here for the past 7 years on the Sunshine Coast. He practices a full scope of family medicine, both at Cowrie Clinic and Sept Hospital's maternity, emergency, and surgical service departments, and has been involved with colorectal screening as an endoscopist. Did I say that right? I hope so. As well as arranging cancer screening and treatment for his patients and family practice for over 7 years. Melissa Yan is here from BC Cancer today, and she is a promotion specialist from the BC Cancer Prevention and Screening Program. She completed her Master's of Public Health at UBC and now works in the areas of health promotion, health literacy, and patient education to help empower patients like us to take control and to improve their health. And last but not least, we have Dr. Stuart Bax, all the way from Victoria, who is a physician with CanScreen BC. He completed his general practitioner specialty training in London, and then after earning his undergraduate degree from Oxford and Bachelor of Medicine and Surgery from Warwick University, Dr. Bax joins us today from Victoria, where he now serves as a family physician in both private practice and walk-in clinics, and he runs CanScreen, which is a virtual service available to everyone in British Columbia, dedicated to improving access to cancer screening and surveillance. So, without any further ado, allow me to get out of the way and invite Dr. Ted to the screen and let you go from there. Thank you so much, everyone.
So I'm going to go through Screening 101 here and try and give you a little bit of background about screening in general and how the cancer screening programs have been developed and brought out, so that you can have a little bit broader understanding of where we're coming from, why we do what we do, and also why we don't do some things that maybe you think we should do. So, as Jane said, I'm Ted Cricken. I work here at the Cowrie Clinic in Sept and at the Sunshine, or at the Sept Hospital. I have no conflicts of interest. I don't work for BC Cancer. And the first thing that we're going to talk about in terms of your Screening 101 class is, why do we screen? And an important point here to make is that screening is for patients that don't have any symptoms, or they have very, very early symptoms. So if you have symptoms already of something, you're worried about a disease or a cancer, then you should actually be talking to a practitioner about getting that diagnosed and treated. And that brings me to the opposite, which is why don't we screen, and that's for people who have symptoms. So if you have symptoms, this is a really important point, you actually need more urgent diagnosis and treatment than a screening program. And my example of that is, if you've noticed a lump in the breast, you shouldn't be waiting around for your screening mammogram. You should be seeing a doctor or a nurse practitioner, getting that actually checked out. So if you've already got something you're worried about, we're not talking about screening at all. So go see somebody, try and get in where you can, and get that looked at. Screening is for that early stage so that we can get ahead of it, as Jane said, and prevent it from becoming a problem. So my next slide is going to be a very busy academic slide, and this is Screening 101. It's a university course, so take some notes. But I'm going to go through a very busy slide and try and distill it down in a way that's easy to understand. So Wilson and Youngner are epidemiologists who came out with a set of principles on how we should design and implement screening programs. So I'm going to go through, there's 10 principles, we're going to talk about them. The first one is that whatever condition we're screening for should be an important health condition. It should be something that actually we should spend the money screening for. The second one is that we should actually understand enough about it that we can find a test for it, find a treatment for it, and we know how it progresses. And thus that there is an early stage or a latent stage in the disease where we can pick it up, make a difference, diagnose it, treat it, so that it doesn't become a problem. And there should actually be a test for that early stage. So if we know all about it and we know there's a latent stage, but there's no way to test for it, then there's no point in screening for it. And that test should actually be acceptable to the population. So my favorite example of this is that we have all kinds of internal organs. They all have the potential to develop cancer. The best way to tell that would be to bring you to the operating room, open you up, and look at all of your organs. But doing that every 2 years isn't actually going to be acceptable to most people. And there should be an agreed-on policy on who we treat if we do identify disease, and then we should actually have a treatment for it. So if we go to all the trouble of looking for and finding diseases and developing tests, but we don't actually have a treatment for it, again, no point in screening for it because there's nothing we can do. And then following on that, we actually need the facilities to diagnose and treat it. So again, we can spend all that money finding it and knowing that there is a treatment down at the Mayo Clinic, but if we don't have access to doing that diagnosis or that treatment, there's no point in having a screening program here. And then this is the key one here is that the cost benefit of doing a screening program, and this includes the cost of the screening program, then the diagnosis, then the treatment, has to be feasible and palatable to whoever's paying. And here in BC, that's the voting public, there's an election coming up, has to think that that disease or that cancer is worth paying the money to screen for, diagnose, and treat, and we actually have to have enough money in the healthcare budget to do it. And the last point is that it has to be a continuing process. So we can't just do it September 26, 2024, we did mammograms for everybody. Great, you're cancer-free, Go home, we don't need to see you anymore. No, because it's an ongoing process. You can still develop it. You have to keep doing screening. So these are the principles that we live by when we're trying to develop screening programs, and public health specialists and epidemiologists try and develop how we actually start screening for something. Now, the big screening programs that we're going to talk about a lot today, they actually tick all of these boxes. They actually are important. We know how they work. We have a test. We have a treatment. We have agreed as a general population that we want to pay for this and do it. But not all cancers fulfill all those criteria. And that's why we have the big four, as I like to call it, that we're going to talk about today, that we have big established screening programs for, but there are actually hundreds of cancers out there. And they don't all have a screening program because, yes, they're mostly important diseases. We know a lot about them. We would plan to screen them continually, but there may not have an early or a latent phase that we can recognize. They may not have a suitable test, or if they do, that test is not acceptable to the population, or a lot of cancers we don't actually have a good treatment for. And then again, referencing our political budgets and things, the facilities may not be there, MRI scanners, PET scanners, et cetera, bug your MLAs. And the cost may not have been deemed worth it. So that's why we don't actually screen for all cancers. That's why we only have 4 big ones that meet all of those criteria. So the next thing I want to impart upon you with this conversation is the concept of risk. And this is where the genes come into things a little bit more. The first one is average risk. So this is the average person where we can't actually identify anything about your medical history or your exam that puts you at any higher risk than anyone else of whatever the disease is that we're screening. And the opposite of that is increased risk. So there is something that we can screen for, or that we can see in your history or talk to you about that makes you at higher probability of developing a cancer. And the degree of risk is actually what can change how your screening works. So hereditary cancers in the family, whether you're a smoker, lots of different risk factors like that, they can actually change your risk and change your screening. And the couple of examples are if you have a first-degree relative with colon cancer, you should actually bypass the FIT screening at the lab and you should be going for a screening colonoscopy. And that's a different way of screening. It's still screening, but it's a different way. It's a little more intensive. Or, as Jane mentioned, the hereditary cancer screening program. So if you have a really strong family history of cancer in general, or if you have first-degree relatives with cancer, for any of these big 4, that's probably going to change your risk profile, and you should be talking to a practitioner about whether that means you should be seen by the hereditary cancer clinic, or whether or not, despite that family history, you may still fall into the regular risk category. And that's where things get a little bit tricky, and there's a lot of back and forth about that. But the big message from this is that if you're increased risk, you need to talk a little bit more about that with someone who knows what to look for, what exact family history is relevant, because a lot of patients come in and say, I got lots of cancer in my family. But automatically I'm thinking, okay, is that in a father, mother, aunt, uncle, son, daughter, sibling? Those are the questions that I want to know, because if it was just in your grandfather on one side and a grandmother on the other side, that's not actually all that strong with a genetic link. But if your grandmother had it and your mother had it and her sister has it and your sister has it, that's really strong link that we need to know about. So if you have a strong family history, you should be talking to a practitioner about what that means. These big 4 screening programs, however, and the DIY nature of them, the big target for this is the average risk person. So the person where we haven't really picked out anything that makes you at higher risk than anyone else. So what do we screen for? What are the big 4? You've heard about them already: colon cancer, breast cancer, lung cancer, cervical cancer. These cancers all tick all those boxes on that big, scary list that I had up earlier. And I just wanted to mention a couple of other cancers that we do screen for in our practices as practitioners, doctors, nurse practitioners, but they don't actually tick all those big boxes or all those 10 boxes on the screening list. So skin cancer is one of those. We do screen for it. We do encourage you to get screened for it. But because there's a lot of variation in what's out there for skin cancer, that's something that needs to be done by a provider for you. It's not something that BC Cancer has rolled out a program for. And prostate cancer is another one. Prostate cancer screening is a huge talk all on its own because there's controversial evidence, there's differing opinions with different medical bodies. We still do screen for it actively, but again, because it doesn't tick all those boxes, there isn't a big established prostate cancer screening program. So we're going to move on. We're going to talk in detail about the big 4 cancers. And so I'm going to ask Melissa to come up and join us.
Okay. I'm not as tall as Dr. Cricken, but thank you, Dr. Cricken, for the introduction. And thank you all for the opportunity today to talk about the big 4 screening programs that we have in BC. So as Dr. Cricken mentioned, we'll go through the who should screen, what are the screening tests, the when, but we'll focus mostly on the guidelines for those that are at average risk, because that's the majority of people. And with the interest of time too, we don't have more than 15 minutes to go through all the guidelines. And then we'll talk a little bit about where you can get some more information. So again, as Dr. Cricken mentioned, screening is to help prevent cancer, help catch it in its earliest stages before symptoms develop. So if you're experiencing any symptoms, then screening would not be the correct path or the right path to go. And that's because when we're looking for things a little earlier, there are more treatment options and a better chance of recovery. And BC Cancer oversees the 4 screening programs. So those are for breast, cervical, colon, and lung. And what that means is we support things like the reminder letters, making sure the programs are running as they should, facilitating the diagnostic investigation and referrals for that. So we have BC Cancer has your back when it comes to reminding you to go for your screening, but also making sure that you have those referrals to go for diagnostic if your results show that you need that. Before we dive into the details, and Dr. Cricken touched on this already, but a quick test, so true or false, even if my result is normal, I still need to return for screening when I'm due. So, I see a lot of great, awesome, and that's right, so it's true. So screening works best when you're getting regular screens or your routine screens so that then we're monitoring for any changes and we can act upon them as quickly as possible, again, before symptoms appear. The first program we're going to talk about today is breast screening. And before we dive into those details, I'd like to introduce Sharon. She's a breast cancer survivor, and she had shared 2 days after my mammogram, BC Cancer called me. They found out I had a small lump. When my doctor told me that I have breast cancer, I just fell apart. Is this true? But 5 years later, she's going to be cancer-free, and she's so grateful that the mammogram had saved her life. So this is just another example of why my screening is so important. But what exactly is a mammogram? So mammograms are x-rays of your breast done in a private room by a female technologist. We'll take 4 pictures, so 2 of each breast, and look for hidden cancer. Again, it's for people without symptoms and who have never had breast cancer. Screening mammograms are available to people for women ages 40 years and older without symptoms. As Dr. Cricken mentioned, those at higher risk may start screening earlier. So again, those guidelines are different for those at higher risk. But mammograms are also available for many two-spirit, transgender, and gender diverse individuals as well. And as Dr. Cricken mentioned as well, so if you have symptoms such as like a new lump or nipple discharge or something just isn't right, then the right thing to do would be to go to a healthcare provider to get that checked out and not go through screening. In terms of how often you need a screening mammogram, that really depends on your age and again, your risk. But for most people, it's every 2 years. But if you have a parent, a child, or even a full sibling who has had breast cancer, then you may need to come back every year instead.
So now that you have your mammogram, what can you expect? So then within 3 letters, BC Cancer will mail you a letter with your results and a letter to your healthcare provider as well. If your result shows that additional tests are needed, a diagnostic facility will actually call you to book an appointment. And just remember that this doesn't mean that cancer was found. It just means that they need to take a closer look at a certain spot. And most people who are called for additional tests don't have cancer. So it's really important to go for that diagnostic investigation just to make sure everything is okay. So with all that said, if you're ready to book a mammogram, you can actually do so directly by calling the screening center, and you can find your closest screening center by going to the screeningbc.ca/breast website, and we have a clinic locator. Or you can call our client services program, and they can help you book an appointment. If you've already had screening mammograms and you receive an invite letter from us in the mail, you might see that there's a booking code, so now you can actually go online and book your appointment. So next is cervix screening. As you may have heard, in BC now we have 2 ways to collect a sample for cervical screening. I have one of them with me today, and this goes back to the DIY part. As you may have heard, we now have cervix self-screening, and what this means is that people who are eligible between the ages of 25 to 69 can now collect their own vaginal sample wherever you feel safe and comfortable. So that means you don't need to go see a healthcare provider to get your sample collected. You can just request your kit from us, and then we'll mail it directly to you, and this is what it would look like when you receive it in the mail. So it comes in this nice little folder. On the side, you'll receive a page of instructions with some images, and all you would need to do is take this swab. It almost looks like a COVID swab, but for down there is what some people have described it. And yeah, so this is the cotton swab. There's a red line on the swab. You would just hold it there, and that's how far you would go up, and then rotate inside the vagina for 20 seconds. So it's not going all the way up to the cervix because this swab is looking for high-risk HPV, so it's a very common sexually transmitted virus. Alternatively, you can go back and get a traditional Pap test. So that's when a healthcare provider would collect a cervical sample. And this is ideal for people who don't want to do this. So this is just an option, or they're not able to or ineligible to do the self-screening. And we can talk a little bit about that in a bit. And the Pap test looks for abnormal cell changes. So compared to self-screening, which looks for HPV, which causes cervical cancer, we're actually looking for cell changes with the Pap test. So the changes are already happening. But now the lab also has the ability to look for HPV with the Pap test sample as well. So who should get cervix screening in BC? So anyone with the cervix, including women, two-spirit, transgender, and gender-diverse people between the ages of 25 to 69 who are not experiencing symptoms. So I don't think we can emphasize this enough, but if you're experiencing bleeding after sex or even pain during sex, then in that case, you would want to see a healthcare provider to get those symptoms checked out. We'd also like to share that cervix screening is still something that should happen regularly, even if you've had the HPV vaccine, you've been through menopause, and if you've ever had any sexual contact with another person of any gender, even if you're not sexually active right now. And specifically for cervix self-screening, it's not for everybody, but we don't recommend it for those who are, again, experiencing symptoms. If you're pregnant or using a pessary, in that case, you would want to see a healthcare provider to discuss your cervix screening options. And if you've ever had your cervix removed, such as having a total hysterectomy. And if you're not sure, then it's great to talk to a healthcare provider to see if cervix screening is still needed. And now, how often should we screen? So for most people, again, average risk, if your result is normal after the cervix self-screening or an HPV test, then you can actually come back in 5 years versus the 3 years with the traditional Pap test. So we can wait a little bit longer because the HPV test is more sensitive, so it's better at detecting HPV, meaning you can wait a little bit longer until your next screen. And again, so after you've had your cervix screening, what can you expect? Within about 4 weeks, you can receive your results in the mail, or online on Health Gateway. So it's the same app that you would use to check your COVID results or your COVID vaccine. And if your result is abnormal or HPV positive, you may be recommended for a follow-up Pap test. So if you've done the self-screening, we'll tell you to go see a healthcare provider to get that Pap test, or you'll be referred for a colposcopy. And what is a colposcopy? So it's just an exam where we take a closer look at your cervix, and it's just a quick procedure that you would have to do at a hospital, but you don't have to stay overnight. And it may just feel like a small pinch when a tissue sample is taken. And we also wanted to share that if your result comes back HPV positive, that doesn't mean you or your partners had other sexual partners during your relationship. So this is a question that we've received over the last couple months. Again, because HPV is very, very common. Most sexually active people will have HPV at some point in their life. You may have contracted it many, many years ago. So it's something that's around and it's very common. So if you'd like to request your cervix cell screening kit, you can do so again by calling our client services or even going online to our website and completing an online request form. You actually don't need a healthcare provider anymore to be able to request the cervix cell screening kit. If you don't have a provider and your results require follow-up, then we'll connect you with the clinic that can help support you through that process. And I know the patient stories are so important, so we wanted to introduce you all to Christina, who shared, "Cancer's in my family, but I never thought it would affect me. Had I not done the cervical self-screening, I wouldn't have known. I maybe wouldn't have caught it in time, and history repeats. So I changed history. I let it not repeat. I did that. I did the self-screening." So next is colon screening. And in BC, there are two ways to collect a sample for colon screening. There are two colon screening tests. And going back to that DIY component, there's the FIT test, so the fecal immunochemical test. And I also have a sample of that. So after your provider refers you or provides you with the requisition, you can pick up this FIT test at a lab, a participating lab. And what it looks like is, and this is what you would receive. So you get a Ziploc bag with the instructions and a tissue paper, as well as the test itself. And it's just this. And it just collects a sample of your poop because it looks for blood in the poop, which could be a sign of precancer. And the other screening test is a colonoscopy. So that's where you would actually have a healthcare provider insert a mini camera and look inside your colon. And it's recommended for those at higher risk or who have an abnormal FIT result. And who should get colon screening in BC? So anyone between the ages of 50 to 74 who are not experiencing symptoms. So if you have symptoms such as you notice blood in your poop or you've had some changes in your bowel habits, then talk to a healthcare provider because you would want to get those checked out and you wouldn't want to get screening done. And for most people, starts at age 50, but if you're at higher risk, then you may actually be recommended to start screening earlier. So you've had your colon screening done, and now what can you expect? If your FIT result is normal, you'll be recommended to screen with the FIT again in 2 years, and you'll get those results online on Health Gateway, or maybe even your healthcare provider will tell you. But if you require a colonoscopy, when you return for screening will depend on your colonoscopy results. So that could be in 3, 5, or 10 years. So your healthcare provider will be able to tell you when you'll have to come back. If you're ready to get colon screening, you can speak with a healthcare provider to see whether a FIT or a colonoscopy is recommended for you. And as expected, so here's Ray. He's a colon cancer survivor. He had an appointment. He says, "I had an appointment with my doctor and he ordered a FIT test. They found blood, so we booked a colonoscopy. I went in, they scoped me. The doctor wrote on a piece of paper, 'Small lesion, looks like cancer.' The lesion was extremely small, very easily operated on. They checked everything and it hadn't spread. So I listened, they caught it early, I'm cancer-free. And his takeaway is to get screened for colon cancer. It will save your life. It saved mine." And finally, the fourth of the big four is lung screening. So this is this is the newest cancer screening program that we have in BC. And how lung screening works is that a low-dose CT scan or an LD-CT scan will take detailed images of your lungs. It's a safe and effective way to screen for lung cancer, and it can show more details than a chest X-ray. And our lovely medical imaging team here would be able to be the ones to help facilitate that. And who should get lung screening in BC? So not everybody, or we've been talking over the past couple programs that it's for most screening programs are those for at average risk, but for lung screening, it's for people ages 55 to 74 who have ever regularly smoked, who are at high risk for lung cancer. So it's a more specific group, and again, not experiencing lung cancer symptoms. So if someone is experiencing coughing that doesn't go away, or shortness of breath or chest pain that's always felt or gets worse, when they're breathing deeply, then again, they would want to go to a healthcare provider to get those symptoms checked out. So you've had your low-dose CT scan. What next? Within 4 weeks, you'll receive your results in a letter in the mail, again from BC Cancer. And if your result requires further testing, so they need to look at a certain spot more closely, you may be recommended to come back for a follow-up low-dose CT scan in a couple months, or be referred for a diagnostic investigation such as a lung biopsy, where they'll take a small sample of your lung tissue and look at it more closely under a microscope. So if you think you might be eligible for lung screening, you can call the lung screening program at the number on the screen. And what will happen is a patient navigator from the program will ask you questions about your smoking and health history, again, so that then they can assess whether you are at high risk for lung cancer. And your answers to those questions will help determine, again, your risk and whether screening is right for you. And finally, here's Shannon, a lung cancer survivor. She said, they removed the cancer, which was the size of a dime. Because of the early detection in the CT scans, they were able to find it at such an early stage that all was required was removing the cancer. I know it's scary. Nobody wants to be told they have cancer. But if it's detected early enough, chances are they can do something about it. And here is just a summary of all the different programs we talked about today, with a breakdown of who should screen, what are the screening tests, and how often do most people get screened. I know it's super busy and it's a lot of information, but if you do want more information, you can always pick up some brochures in the front lobby that covers all of this information. Go to our screeningbc.ca website, which also has links to our YouTube channel where you can actually watch all the different videos of the patient stories that I shared today. And thank you so much. Now it's my thank you. That was a lot of information, so I appreciate everyone's patience as I went through that, but it's my honor now to introduce everyone to Dr. Stuart Bucks.
Hi everyone, so I'm Stuart Buck. I'm a doctor from England initially, but really pleased to be here now and made this my home. Sorry. How's that? There we go. Perfect. So yes, my passion is in preventative healthcare, family medicine. I do a lot of work in unattached settings such as walk-in clinics. I myself do not have a family doctor, and my family does not have family doctors, so I understand the concern. And whilst I am a doctor myself, the college frowns upon us treating ourselves or treating family members. So yeah, I feel that pain. And that's really what brought me and my colleague to create this organization called CanScreen. It was really to try and help facilitate people who either do not have access or have difficulty accessing the system to get preventative medicine. We wanted to do a clinic for all of preventative medicine. We recognized that was quite high, so we started off with cancer, because as we can see, we have very clear screening pathways, we have great evidence-based screening tests, and we have very good ways of managing those results once we get them in. And really what led us down this path was my work in the untouched setting, where I see people often in crises, but we're missing that preventative bit. People, it's either an afterthought to us as clinicians, or people just aren't going to queue for 6 hours to come and see us about getting a fit test requisition or a colonoscopy requisition. And these are the stories we're hearing. I was never able to access primary cancer screening, waited in line in various walk-in clinics for over 6 hours, and ended up leaving before meeting with a healthcare professional. I have no access to any preventive care, no GP, no MP, nothing. Very scary. And so a colleague and I decided to start CanScreen. And in essence, this is what we're trying to do. We want to facilitate evidence-based cancer screening and surveillance services. We offer continuity of care, and I think this is the real key piece, and this is what the unattached or people accessing the system miss, is that continuity of care. And there's been a big push for attachment by our politicians, and it's currently top of all the healthcare agendas. But the reason attachment is so important is that continuity piece. Your family doctor will know your history. They'll know your family history. They know what tests you've already had. They know what risk factors there might be. And if you have a diagnosis, they can help support you down that entire journey. So for patients who screen with us and get a positive result, when I say positive, I mean they get a cancer diagnosis, we're going to support them every step away as far as we can go with those further investigations and subsequent treatment as well. The aim is to be complementary. We're not trying to replace anybody. We're here to complement the family doctors, the nurse practitioners, and the urgent care settings, and hopefully take some of the pressure off places like the emergency department as well. Perhaps a bit of background first, though. One of the reasons this issue currently exists is a bit technical. It's just legislation. Currently, almost every test ordered has to have a provider's name attached to it. The HPV test, which I'll touch on again, is the first test of its kind where actually now you can get that requisition, whether you've got a doctor or not, or a nurse practitioner or not, that you can get straight and request to self. But every other test does have to have a provider on still. And the other part of that is to receive the results. Some of these results are not always black and white, and some of them need further follow-up. So you've got a primary care doctor. How you access these tests is super simple. You do not need our services. You can go and see your family physician. They will be able to discuss your risk. They'll be able to arrange appropriate breast cancer screening and colorectal cancer screening, and potentially lung cancer screening as well. In addition to that, as has already been mentioned, the HPV test, you don't have to see your family doctor for. You can actually just go online, go to the website, order that self-swab kit at home. However, there are some people who will still require a PAP, and obviously that needs to be done in person. The breast cancer screening system is also similar. And although there we have the hot number, similar thing, if you have a family doctor, you can call that number and you can get booked under your number. I'm pleased to say for unattached patients now, we've also got that in place. So if you do not have a family doctor, you can also use that centralized telephone number to book your mammogram. And all you have to do is, if you want to book with our clinic, you can say you're going to be booking with CanScreen, and they will book you in at the next available test at your closest screening site. So you don't need to speak to us in advance. You don't need to get a requisition from a walk-in clinic. You can simply tell that to them once you ring this number. So no different to your colleagues, friends and colleagues who might have who are family doctors. Breast, for other screening tests such as fit tests, colonoscopies and lung screening tests, then you'll need to book with us so we can go through your risk history and order that appropriate investigation, that appropriate test as well. And this is what the booking process looks like. So we've basically highlighted each test in turn, hopefully making it as simple as navigate as possible. The website has other information about it. It has information about those people who've got symptoms. It has information on eligibility criteria, and when we really stress again that if you do have symptoms, where you should be seeking some further support from. Depending on which test you're booking, you'll find you'll be prompted to input your demographic information, including your PHN number. This basically builds your profile on our EMR, the electronic medical record system, and it's where your result will get attached to. So when that screening test is done, it all gets put back into the system straight away. The one exception to that is the HPV screening. That obviously, if you realize you're eligible for that, that link directs you straight back to the BC Cancer website where you can order that yourself and you can do that swab for yourself at home. The one extra thing which we haven't talked about today, which we offer, is the cancer surveillance. This is a little bit different to screening. This is geared up to people who've already had a cancer diagnosis. They've been treated. They've been discharged from BC Cancer, but they need ongoing surveillance. Surveillance is another type of screening, but it depends on the type of cancer you've had, and you'll have very specific instructions, such as needing a CT scan every 6 months or needing a certain type of blood test every year for so many years after those tests. And we've certainly encountered patients in the community who, once they get discharged from into the community, they don't have a family doctor. Again, they're lost to these services. You're busy trying to queue for walk-in clinics, trying to be they get a telehealth call with TELUS or one of the other companies, and getting that continuity is lost. So for those patients, we also offer that continuity piece, and we can support you during that surveillance journey. Once you've had your appointment and you've completed your kind of screening questionnaire, which you'll be asked to do at that time as well. You'll be speaking to one of my colleagues. We basically go through that risk questionnaire. We review your symptoms. If you have symptoms, we review your family history. We review your personal history, and we'll decide what tests might be necessary. We can divert you down the FIT path or the colonoscopy path. We can arrange lung screening tests. We might also be saying, you know what, things are really high risk. We should actually get referral into the hereditary cancer screening program as well with BC Cancer, one of the other high-risk programs. So this is where the input, it's a telehealth conversation, but this is where that conversation can be happening. If you're not sure if you fall into those categories, again, you can book online and we can have that conversation. So you don't need to go and book that test directly if you feel like you might need more regular screening or a different type of screening test. Once we get the results, we follow up on all results. We don't go by the no news is good news. That really just stems from a way of dotting the I's and crossing the T's. We want to make sure there's never a situation when someone's sitting at home assuming all is well when actually results never been seen. And sadly, the system is not perfect. The computers do not always talk to people. And again, for those patients who have lost their family doctors, we've seen cases where results have gone to your retired doctor and it hasn't got back to where it's meant to go. So we encourage patients to, if you haven't heard from us and it's been more than a couple of weeks since you've had your test, then you're welcome to book that follow-up appointment and we can rediscuss your future screening recommendations and the results as well. Generally speaking, it works well though, and you'll get an automated email once those results come in. FIT tests, we're looking at about 3 to 4 days. Mammograms, about 5 to 10 days. Colonoscopies take a little bit longer. They're more like 3 to 4 weeks, and that's partly because we're looking for different parts of that report to come in. The last piece being the histology, which is when they look at it under the microscope. So we want to have all those pieces together to talk about your next recommendation and guidance after that time. Positive results are handled much in the same way, except we're going to be badgering you. We're going to be chasing you down. We're going to be putting phone calls in as well to make sure those results are appropriately followed up. Usually, we haven't got definitive results. It just means you're getting that next test. You're getting that diagnostic test to further review that pathway, further review that process. So, in essence, we've hopefully made this as easy as possible for you to book these screening tests. We know doing it when it's at the forefront of your mind is important. We've got availability usually within 1 to 2 weeks, so it's not big waits to get these tests completed. The one final thing I would stress is that continuity piece. And this really is one of the cornerstones to your care. And even if you don't have a family doctor, even if you have struggled, some of these tests can also be organized by any other healthcare practitioner as well. If you already have a relationship with a walk-in clinic, if you already have a relationship with one of the online doctors like TELUS, then by all means request it through them. Having all your information in one place is really important. It's important for your care, it's important for your team, and should ever there be a positive diagnosis and a cancer diagnosis, that continuity is really, really important. So with that, short and sweet, and then I'll pass this back to Rivka.
Okay, thanks so much, everyone. What a great set of presentations you just made. And now it's your turn in the audience. If you have questions, please take a moment to jot them down, and some of our staff and board members hopefully can help us be the ushers to collect them. We did actually have one submitted as you were all taking your seats. So let me start with that. And that goes to, I think, Dr. Ted and maybe Melissa. So here's a question. If you have a sister with breast cancer and you're eligible for the BRCA gene test, would you be eligible for the BRCA gene test, or would you have to go pay for it privately? This person's applied for it well over a year ago and has had no response. What should they do?
All right. Well, that speaks to your level of risk for breast cancer, I guess. So having a sibling with a cancer obviously puts you at an increased risk. In terms of the BRCA test, that is a hereditary cancer. And as Dr. Bax told me earlier when we were discussing this kind of thing, Cancer is very common. It's very common to have relatives with cancer, but hereditary cancers are not common. So BRCA is not common. So just because you've had a sibling with cancer doesn't necessarily mean you need to be tested for BRCA. We have to know if your sister had BRCA in her genes, because it would have been tested when she had her cancer diagnosis. And if she did, then yes, absolutely, you would be eligible and you should be seeing the hereditary cancer program. If she did not have the BRCA gene or was not tested for it, then just the fact that you had a sibling with breast cancer doesn't necessarily make you eligible for that test. So what I would recommend in that scenario is to talk to a provider and go through the questionnaire about the hereditary cancer program. And if we know enough about your sister's diagnosis to make that call and she was BRCA positive, then yes, you should absolutely have that test. If not, you might not be eligible for having it done through the public system. But yes, you have that option to go pay privately for it, and that would definitely be faster.
Okay. What is the rationale behind aging out in the screening processes, e.g. colonoscopy and mammograms are not done over a certain age? Is it lifespan or cost or someone's really cranky or what? Thank you, Stuart.
So, we hear this a lot, and I think comes back to Ted's first talk. It's about population level risk. These screening programs have been designed around population level analysis, not individuals. Although you may age out of a screening test, does not mean you're not eligible to keep having screening tests done. It just won't be for the BC cancer normal screening pathways. So in those situations, I'd say it's well worth talking to your provider. Again, that's something we can support if you do not have a provider, but it's all about that. Then it comes back down to personal risk. It's not meant to be insulting. It's not meant to say you're not going to be living longer. We know lots of very, very healthy people in their 80s and 90s who absolutely a screening test. And I think here's the big thing. If you've got a screening test which actually has a positive result and it's going to lead to further testing, if you're fit to have those surgeries and that subsequent testing, then absolutely you should continue screening. When I would stop screening is when, for whatever reason, we expect you will not do very well if we do those further testings or do very well in those surgeries, for example. And that's when you might want to reconsider whether having unnecessary testing at that point going forward.
And I would just reiterate that a little bit more. The population level decisions and the giant list of criteria were designed on how to catch people in their time when they're at risk and they would be healthy enough to have, usually for cancer, it's a surgery to remove the cancer and then possibly going on to have a radiation or chemotherapy, which isn't easy on your body either. And the people, on average, when a lot of these screening programs were developed, were hitting 75 or 70 or whatever the age was. That was the turning point when the epidemiologists were looking at the data where it might not be feasible or the cost benefit of screening that population might not be worth it anymore. But as Dr. Back said, if you are fit and healthy and willing to do screening and you feel that you would go ahead and do those treatments if you picked up a cancer, you should still be screened. It just won't be through that formal BC Cancer program. It'll just be with your provider.
Here's one. My friend died earlier this month, 1 month after she was diagnosed with stage 4 pelvic cancer. She was very fit, never had any symptoms or illnesses prior. Is there any screening available for ovarian or pelvic cancer that you know of?
The pelvic we're usually talking about either ovarian or endometrial cancer for this. And that falls into that category, that slide of cancers that don't meet all of those criteria where a formal screening program would be feasible. And it's mostly because ovarian cancers in particular, they're very diverse in how they present and usually very vague. And there isn't a really good early latent stage because it kind of goes from 0 to 60. You either have no symptoms at all or you have lots of symptoms. And we don't have a lot of data on how long it would take between screening tests to pick that up that would be safe. The current evidence would be saying we should probably be doing an ultrasound of your ovaries every 6 months in order to pick it up in time to do something about it, which again is not cost effective. So unfortunately, where we are with the screening test, which is only imaging at this point, we don't have a screening test for it, and that's why we don't screen for it. You know, stay tuned. There's lots of money going into research about blood tests and biomarkers, but we don't have anything yet.
We have tons of questions, so if we don't get to them all, we will do our very best to have a summary of answers and available on our website. But let's keep going. What if screening mammogram shows a need for a diagnostic mammogram and it doesn't show anything? Diagnostic mammograms still see a 4-centimeter lymph node, but asked to go back to a 2-year screening. What happens to the lymph node? Nancy? Sorry.
So that sounds like a very specific situation. From a purely processes, if you have an abnormal screening mammogram, so this is when something is detected, it might be an asymmetry, it might be a little lump, you'll automatically get referred for a diagnostic. Diagnostics are generally more intensive, and they might do further testing and further modalities like an ultrasound scan. They might even do a biopsy at the same time as well. There's many ways the radiologist and the radiographer interpreting those results can tell if something it looks benign or sinister. So without knowing that case specifics, I would assume that it's being reviewed and it looks like a benign lymph node. However, the prerequisite would that be, that's always worth having a discussion with your provider about as well. There's another aspect to this, and I suspect might be at play, and that's something called breast density, which a lot of you will hear about in the media and the news. It's quite a big topic at the moment. And that might change that recommendation slightly, because if there is proven dense breasts on that mammogram and that screening scan, that might also change your future screening recommendations as well. So, case-by-case basis certainly needs to be reviewed. The other thing which makes breast a bit more challenging is if there's any new lumps and then there's a negative mammogram, that should again always be seen in person. We will act upon sinister examinations even in the presence of normal tests. And this comes down to the fact that no test is 100%. We're playing averages, so any uncertainty always worth following up with the
And I just add as well that, if you have a positive lymph node or a lump, that almost kicks you automatically into diagnostics instead of screening. So we should be following a diagnostic pathway, and you should talk to your provider more about what that means for you.
What options do I have if I don't have a family doctor and not have a family doctor? What annual tests should I be asking for?
Okay, so if you don't have a family doctor, you have, broadly speaking, walk-in clinics, UPCCs, which are the urgent primary care clinics, some of the telephone medical services such as TELUS and TIA. We are dedicated to cancer right now, but we're hopefully going to be doing some further work on preventative medicine down the road, but currently cancer-orientated. And there's no annual test per se, unless you've got a strong family history, in which case there might be an annual mammogram, for example. Each screening test has their own criteria, and it will depend how those screening tests are and those results, which dictate where you're going down on that screening pathway. But generally speaking, you're looking at for an average risk person, every 2 years for a mammogram, every 2 years for a FIT test, every year for a lung cancer screening if you are deemed to have high risk for lung cancer, and 3 to 5 years depending on where you fall into the PAP or HPV screening pathways. There's no annual blood tests which are actually recommended from a cancer screening standpoint. Depending on personal history, there might be some screening blood tests for other metabolic illnesses like diabetes, but again, that would be something to have a case-by-case personal conversation with your provider, or one of those options for those unattached patients.
Great, thank you. I read in the news that there is a lung cancer vaccine now in human trials. Do you know anything about how it works, and is there any possibility that this will be applied to other cancer types in the future? If you had a crystal ball, you should really tell us now.
I don't know how it works. I know that there's a lot of research in this area right now. There's And vaccinations for cancer is a huge, big area of research. And I do believe this will be coming down the system. I do believe other cancers will be prevalent for. HPV is a great example of that. HPV, we know the reason we do HPV screening for cervical cancer is it accounts for almost all cervical cancer cases. It's also an incredibly common virus. And since we've been vaccinating our younger population, which has been happening around the world for many, many years, and in Canada relatively recently, we're going to see those cancer rates plummet as well. We also know HPV affects other types of cancers as well, so we're expecting to see those rates be affected, but we don't have that data yet. This is where time helps us. These epidemiological studies we talked about, Ted talked about in the first part of this talk, we need that information still, and we're gathering it. But we certainly believe that the medical profession, we are aware that there's an interplay with viruses, for example, and this is where vaccines might become very important as well.
Melissa, what's the difference between the hereditary cancer program and genetic screening? And how does a patient go about accessing the hereditary cancer program if indeed they have a primary relative?
Now, that's a really great question. So the hereditary cancer program, so just going back to the screening program specifically, the BC Cancer would recommend to the provider to refer a patient to the hereditary cancer program if their breast or colon screening came back or the results showed that a recommendation to that program would be ideal or recommended. And I'll have to admit that the hereditary cancer program is still fairly new. So I'm not entirely sure in terms of like the different types of services or testing that they offer, but I would imagine that genetic testing would be part of that work, depending on why you're being referred to their program.
I can speak to that a little bit. I've had a few patients go down that pathway. And yes, genetic testing will be included in that pathway. The hereditary program is very busy. They have got quite a wait time to be seen by them. The first thing above all else, though, is identifying the true risk. And there's only certain, again, cancers they can investigate. And part of that is a family tree, which they'll ask for at the very beginning. And it might be when they look at that, actually won't go all the way down for the genetic testing part of that test. So again, that personal history becomes more important. And there's a referral sheet to go through with your provider, basically, which might screen you in or out of that hereditary program and deem it whether it's deemed to be necessary going forward as well. One of the big criteria, which was alluded to in the earlier question about the high-risk breast genes, is testing the person who has the cancer is often the first port of call, because if they don't have the genes and actually it was just random mutation, random luck, then there will be no need to go down that hereditary program, for example.
Dr. Cricken, you've been doing some legwork here in Sept with the Cowrie Medical Clinic. Can you walk everyone through sort of how does an unattached patient get access to cancer screening if they want to go in the in-person route?
All right. So if you want to do the in-person, not the DIY route for cancer screening, then you're going to need to speak to a provider. And on the coast, I know that's really difficult, but there are access points. The Cowrie Medical Clinic, where I work, the Gibson's Medical Clinic operate walk-in clinics that are for any unattached patients. If you draw the lottery ticket and get your phone call through at the right time, you can get in and see a provider there. The other clinics on the coast, they are all to some degrees booking same-day appointments for unattached patients. They're just not quite as big and don't have as much dedicated time, but you can also try the other clinics. They can sometimes get you in. That includes Pender Harbor and Arbutus and Upstream. Those are all clinics with doctors that have pledged to do some same-day appointments, but it's just not quite as established as Cowrie or Gibson's. You can access the CanScreen clinic virtually, or any of the other virtual clinics like TELUS, etc., and they can get you started. And they will often kind of talk to you, take your history and see what your risk is, or if you have symptoms, and see if you definitely do need to be seen in person. And then they can arrange that. And I'm not sure if Dr. Bax talked about it, but CanScreen has a network of doctors that they can get in touch with if you need to be seen in person for some kind of in-person exam. They can set that up, and we have providers on the coast who have agreed to do that. So if you go through a CanScreen route and you need to be seen in person, they can get a hold of one of us who has agreed to do that test. So that's where I would start if you want to be seen in person, is somewhere, if there is, again, screening-wise, we're talking about no symptoms. So you're, from a cancer point of view, feeling fine, you don't have any symptoms, then it's not urgent. I would not recommend going to emergency for that, because you're going to wait a long time, and you might have a doctor that says, well, you don't have symptoms. What are you doing here? I can't order your mammogram. I'm not going to follow up on it, etc. If you do have symptoms and you're worried, then that is an access point if you can't get anyone else. But again, screening, you don't have symptoms, you don't need emergency, but you have those other options that you can try. And then obviously I recommend everybody put their name on the health registry, because as we're hopefully adding more doctors to the coast, we can get everybody attached eventually.
Excellent.
I'll just add for cervix specifically, if you want to get a pap test, if you go to screeningbc.ca/cervix, we have a pap test clinic locator. So these are clinics that have told the screening program that, hey, we're okay with offering pap tests at our clinics to patients. So you can look that up and see all the different clinics across BC that you could reach out to for pap tests.
And we do have some nurse practitioners that are doing this through the health units in Gibsons and Seashelt as well for pap tests. So if that's what you want or need for your screening, then you can get access to that without a doctor.
On the pap test, you actually helped get me to another question here. If someone is 73 years old and they have a concern about a family history with ovarian cancer, should they still do a pap test?
So ovarian cancer and pap tests, unfortunately, are not connected. Pap tests are all about the cervix, which is a different organ than the ovaries. And so if you're 73 and you still want to have screening done for your cervix, you are absolutely welcome to do that. If you would be willing to have surgery and or treatment for cervical cancer and you want to keep on top of that, you go for it. You can get that screening through any of the providers we just talked about or your primary care provider. Ovarian cancer, we don't screen for because, as I mentioned earlier, we don't have a good screen test for it, and we have very little treatment for it as well. They're unfortunately not connected. Just because you've had a pap test or a pap screening or HPV screening for cervical cancer, that won't tell us really anything about ovarian cancer.
So there's a bit of marketing in the general public about some of the paid tests that are available. And I know, Ted, when we were rehearsing, we were talking about the advent of the full body MRI and how that might be a bit of a challenge to some of our physicians. He's smiling at least. Could you say a bit more about those paid tests that are currently available and being very aggressively marketed to the world? And as well, while you're at it, then can you talk about the relevance of 23andMe and what you do with all this information all of a sudden and all this technology?
So generally speaking, I would advise against them. Pretty simply because they pick up things which we don't know what to do with, or they're going to lead to investigations which are going to cause you potentially have their own risk of complications as well. These screening tests we talked about today all got a good evidence base behind them now. We know they're effective. I've had a patient come in who's had one of these full body MRIs. We found something on their kidney. We can't tell by the scan what it is. We can't tell by a second scan what it is. They have to go and have a biopsy. They have the biopsy. They have a rare complication to that biopsy and a big bleed, and they lost their kidney. When we actually got the histology back, which is the microscopy test of this thing we saw in the kidney, it was normal. There was nothing wrong at all. So this is an example where, and I'm saying that's a rare, but it's a true risk of having any investigation. There's always complications and always risks. So then the question is, why do you want to have this test? In a perfect world, great. We should be getting in a shower every morning, have a full body scan. We don't even know it's happened. It gives us our readout. And that's the future. Maybe in 200 years, maybe 500 years, that would be great, but we can't do that right now. So I come back to, why do we want this test? Am I worried about ovarian cancer, for example? Okay, so yes, an MRI might pick that up, but then how often do I get it? We know ovarian cancer generally is incredibly aggressive, which is what makes it so challenging. The reason lung cancer and the reason colon cancer and breast cancer is so easily screened is that actually those tumors tend to grow relatively slowly. Colon in particular will grow over several years. We've got time to pick it up. But ovarian or pancreatic is the other one I hear about a lot. Very aggressive cancers, they can grow very quickly. So do we scan every week? Do you have that MRI scan every 2 weeks, every 2 months, you've got to level that anxiety you have about possibly having a rare condition versus the anxiety from having a skin test for 7 months.
Ghost.
I'm not doing anything. Yeah.
I think you've kind of summed up the main points of it, is that, knowledge is power, except sometimes it's not. Sometimes you don't know what to do with so much information. And especially the things like the full genome tests and that tells you, oh, you have all of these things that are associated with cancers or conditions. There's no studies actually yet showing that knowing that and acting on that prevents any disease. There's lots of studies showing that knowing that and investigating that causes harm. So it's, again, a question. Do you just want to know? Do you want to act on it if you have this knowledge? And in which case, what are you going to do? How are you going to act on it? Because as medical providers, we don't actually have that knowledge on what to do about a lot of these genes that show up. We can say, oh, yeah, sure, that looks like a lot of those genes are associated with cancer, but we don't have a screening test for that. And I would go back to my giant list of Wilson and Youngner's criteria. Is there a latent phase in this cancer? Is there a test for it? Is there a treatment for it? And just because you have the genes that are associated with it doesn't mean you are going to get it ever. So those tests are they're interesting. A lot of people like to go and do them. Particularly a lot of people when they, go down south for the winter and, in between golf games, they need something else to do. So they go to the local full body MRI clinic. Then they come back to our public system and say, I need to check all this stuff out. And you're like, well, we actually don't check for that. And we don't have evidence to say it needs to be treated. So those tests, they're lots of knowledge, but they're not actually always power.
Okay, I'm getting the hook. Thank you, Spirit. Thank you, panel, very much. And Joanna had one closing question for you, a stumper from the crowd. And that in summary, while everyone's filling out their surveys and their feedback, we'll ask that maybe some of our ushers could collect those. Could our speakers just make one last conclusive statement on why screening, including self-screening, why is it such an important tool to advocate for your own health?
So the screening is precisely to nip something in the bud. It's earlier to know about, or it's better to know about it earlier, so we can give you less treatment or less invasive treatment or a better chance of curing it than it is to find it later and try and deal with the consequences later. So it's all about being proactive and staying ahead of the game.
Well, I don't know how to follow that because that's exactly it, right? And I think we've heard questions today about, oh, should I do this? Should I do that? But here we have a BC Cancer 4 screening programs that have shown to be effective, that have shown to be helpful, that has shown to save lives. So if this is a way for you to actually be able to do that and change history, as as Christina had said in her story, then why not do it? So yeah, I guess that would be our takeaway.
Yeah, and I think to add to that, we're very lucky to have these tests available to us, and I think self-advocacy is really, really important. We, at a time when the healthcare system's being challenged and pressurized at a time when many of us don't have family doctors looking after us. It's up to us to take interest in our own health. It's up to us to take responsibility for our health and seek out these tests as well. So yeah, that's where I really say, advocating for yourself is really, really important.